Welcome, everyone, back to the IMG podcast. I'm your host, Dr. Sami Khalil, and I am beyond privileged and happy to have my friend and colleague here today, Dr. Stephen Winkler.
Hi, how are you?
So, to tell everybody about Dr. Winkler is one of our oculoplastic surgeons. He is an eye doctor, and he's going to talk to us a little bit about his journey into medicine, how he got into there, what led him down this path to become a master of eyeballs, and basically everything then afterwards. And then we're going to talk a little bit about thyroid eye disease, which I know is a passion project of his. So let's get into it.
Currently the only oculoplastics doctor, not just one.
That's right. You are the only one
I am the only one.
in IMG, but now you share your office with at least part-time with your sister, correct?
Yes.
Yes. She is also
She is also a oculoplastics doctor. We're the only brother and sister in ASOPers, period. So
No,
ASOPers
there you go.
stand for American Society of Oculoplastic and Reconstructive Surgeons, which is the governing board for oculoplastic and reconstructive surgery.
Awesome.
So I am dual board certified in both ophthalmology and oculoplastics. So to do that within ASOPers, you not only have to complete a fellowship, but you also have to complete a thesis project.
Wow.
And I think it's the only fellowship that requires an actual thesis project to be entered into the society.
Wow.
So mine was on periocular anthrax and reconstruction.
Periocular anthrax. Now that's interesting.
Yeah.
I'm going to take a step back for just a second because I want to get back to that. I want to understand what the periocular anthrax does do for individuals. But how does one like yourself decide that this is where I want to hang out? Because you had a different trajectory before you were going into medicine in terms of what you were passionate about. One of those things being music.
A little bit. So not quite right, but close.
Okay. Correct me.
I have a poster from when I was in third grade. It says, "What do you want to be when you grow up?" And it says eye doctor.
No way.
So my father is an ophthalmologist, and I always loved what he did. I saw him in the community. He's actually in the northwest suburbs here as well, in Des Plaines. And so I saw what he did for the community. I saw how patients would see him around, just around town, come up to him, "Dr. Winkler, thank you so much. You made my life so much better. I can see." And it was really nice to see that. So I always knew I wanted to go into medicine. And so that's how I decided to become an eye doctor. When I was in medical school, I did a rotation in plastic surgery. And I said, oh, this is actually pretty interesting as well. I kind of really like the geometric spaces and topography. I was a math major.
I was going to ask you, so to say you enjoyed math,
almost got a PhD in mathematics, but I got to the high level maths and I said, my brain doesn't quite work that fast.
Fair enough.
It's another story for another time. So I did my rotation in plastic surgery. I told my dad, I said, "Dad, please don't get mad at me, but I think I might want to do plastic surgery." He goes, "Well, Steve, there's oculoplastics." And that was the moment where my brain just exploded. I said, "What?" So
kind of like that you can put the cheese inside the crust moment. Yes. Yeah, that's right.
Just like that. So I did a rotation in oculoplastics with Dr. A.J. Ahmad, who's actually, he's in the area too. I think he's in Lombard still. And I saw him do what's called a Cutler beard flap, and that's cemented for me. So Cutler beard flap is when you reconstruct an upper eyelid from basically nothing, and you create a bridge. You sever the lower eyelid into a top and a bottom. You bring the bottom up to reconstruct the upper eyelid, and then you release that about 3 weeks later, and suddenly you have two eyelids. I thought that was the coolest thing on earth. So that's what kind of really pushed me towards it.
Those are very, very cool in operations to see. And I know the first time what it was like when I saw a Cutler beard, it was very, very neat. So that's really cool that you had that opportunity and that kind of really got you engrossed into that area.
Yeah.
All right. And so then you went into medicine. You kind of knew that the eye is where you kind of want to generally focus in on. You knew that you were going to end up in ophthalmology. That's kind of where it happened. But in your spare time, I know that you were passionate about music. Is that correct?
Yep. So I've always loved music in general. I got kicked out of my piano class as a child because I would write too much music. They wanted me to do my scales. I said, no, I gotta make music.
That's awesome.
So I played trumpet as a child. I always wrote music. I really liked electronic music. I started DJing when I was 18. Then I started writing music. And so as a side project, I write a lot of music, both on the computer, at home, in my spare time. So,
That's awesome. And now you have also, I wouldn't call it a band, but you have an electronic group. Is that correct?
yep.
What's the name of it? Tell the audience.
South of Boundary is the name of my electronic music group.
How'd that name come about? I'm curious myself.
So back in Baltimore, where I did my training,
Mm-hmm.
through a friend of mine, he introduced myself to our friend Sam.
Mm-hmm.
And Sam is in medicine, more like business side of medicine.
Mm-hmm.
And so we hit it off. We both have a love of like old school hip hop, electronic, world music, Daft Punk, the Chemical Brothers, things
Mm-hmm.
of that nature. So we just started writing music together and have been writing music since about 2015, I want to say.
That's amazing.
And Sam is a boundless uh, well of new musical ideas.
That's
And
amazing.
he's really an incredible creative in terms of how he creates music and comes up with just things that you or I would never think of. And I'm more of the fine tuner. Sometimes I come up with the stuff too, but
That's awesome. And I mean, kudos to you because you've been keeping this up while maintaining a very busy practice and helping tremendous numbers of people in the community. And that's how we met because we met when we first got recruited here to the Arlington Heights area. You had been here and you've grown up here. This has been your home.
yep, you can see my house where I grew up from the top of the hospital.
That's right.
In Mount Prospect, so not far away.
That's right.
And yeah, I got consulted on some really complex patients, and I remember thinking, having grown up in Northwest community,
Mm-hmm.
Arlington Heights, Mount Prospect, I knew most of the surgeons here at the time, and my dad's been on staff at this hospital since forever. And I saw they were going to do some very complex orbital work, and I thought, well, I could probably help with that. At the same time, I thought, maybe at the community hospital, this is not the best surgery to be done because it requires an entire team of people, very close post-operative care, and people who really know what they're doing because you can get into
Mm-hmm.
problems in these surgeries very quickly
Mm-hmm.
that you can't resolve.
Mm-hmm.
And so I called up Dr. Kassan, who called me back. And regarding this specific patient, he said, well, I'm glad that you read my paper on it. And my jaw just kind of dropped because I said, what are you doing in this area? Because this is an academic level surgery, an academic level problem. I had seen one patient in the past with this type of tumor.
Mm-hmm.
And I just saw him. He's doing great. Looks like basically nothing happened. I think it was a 20-hour surgery,
Yep.
something along those lines.
Yep.
So
I was there.
That's how I ended up meeting you guys and working with you. And it's been great to work at IMG and with Dr. Sam, Dr. Khalili, and the whole crew.
Well, we've been blessed to have you for sure, and it's been in so many ways a lot of fun. And as you can probably tell from all of us, we're a group that likes to work hard but also play hard too together. So, which is good. So now that you guys all know a little bit more about who Dr. Winkler is, and I thought we could talk about him as an individual, all the kinds of wonderful, interesting things that he's into for a much longer period of time. And maybe that's what you guys want to learn about later, but we'll save that for a different date. But what I want to talk about with you here is something that we commonly see, you and I, and you are the expert in this, is people who have what we call thyroid eye disease. Now, many of you guys don't know exactly what this is, but I'm going to let Dr. Winkler, in his own words, explain it to you, and I'm going to try to pretend to be you guys and ask the questions what I believe that you might have. So go for it.
So thyroid eye disease, only within the past decade, 2 decades, somewhere in that, we really started getting a lot more information about it. And previously it was always thought to be thyroid related.
Mm-hmm.
In reality, it's an autoimmune disease. Autoimmune disease like lupus, rheumatoid arthritis. So the name thyroid eye disease is a little bit of a misnomer. Yes, there are a lot of thyroid problems that go along with it. That has to do with the autoimmune disease that affects both the thyroid and the eye.
And so for many people, you guys may not understand what an autoimmune disease means, but it means that the body is attacking itself in some way or doing something to itself that's causing the problem. So in this case, is that what's happening, or is it something a little bit slightly different?
No, it's antibodies directed against both the thyroid and some of the receptors in the eye, which can cause basically an inflammatory condition. And there are many different types of antibodies that cause this. In terms of how the thyroid reacts, you can have low thyroid, no changes to your thyroid, or high thyroid. The whole spectrum can be at play with the eye changes. And the most common one that people think about is Graves' disease. So Graves is a specific subset of thyroid eye disease, where you have a high hyperactive thyroid in addition to the eye findings, as well as an elevated antibody, typically thyroid stimulating immunoglobulin. And Graves' disease is kind of the classic picture of somebody whose eyes are pushing forward out of their head. Their eyes get real wide. It can happen to both eyes. It can happen to one eye. It's usually asymmetric as it is. The classic person is Marty Feldman, who is an actor.
Okay.
It might be a little old for people, but he played, I think he was in Frankenstein's monster.
Okay. Yeah, I do remember.
So he's got the eyes that are splayed out and they're real wide. So that's the classic person who had thyroid eye disease. Now, you don't always have to have the bulging eyes. Sometimes you can just have pain behind the eyes. They can look a little bit wide. There's different types. I think the people we think about that is, I can't remember, the entire Bush family had thyroid eye disease. I think it was George, his wife, and even the dog had thyroid eye disease.
Wow. Looking in that, they had anything been reported about any correlation in terms of why the dog also, or just pure luck?
I think it's just one of those funny coincidental things that happen.
Fair enough. So in terms of thyroid eye disease, I guess for the people they want to know, it's like, how would they know that they have it?
But most people start noticing their eye shapes changing. They'll say, oh, one eye is pressing out of my head. My eyes are getting wider. My eyes are getting swelling around them. I'm getting pain behind my eyes. Not just like kind of a feeling like something's in the eye, but a deep Charlie horse pain. Those are all things that kind of go along with it. Sometimes your eyes will get very red, and that's from vascular congestion. So most of the pain from it, as an inflammatory disorder, causes congestion, and the blood vessels have to exit the eye. Because there's swelling and inflammation, those blood vessels get clogged up a little bit, and they can't exit. And that's what then starts leading to a lot of these symptoms.
So basically all the blood is backing up inside the orbit itself. Orbit being this casing the eye is sitting in. Okay.
Correct.
So you were mentioning before that, this condition can be caused by multiple different types of antibodies. Can it be caused by any of the antibodies that we currently ingest, as far as you're aware? Not that we know of. There's been no case report or anything. Okay, that's good. That's good to know. So now, I guess, when this kind of thing happens to people, if they start noticing what you're describing, like the eye pain, the eye fullness, even, I guess, changes in vision might happen along with that. First thing I think you'd recommend is come see someone like yourself to be evaluated, correct?
Yeah. So it's usually best to get in to see an ophthalmologist first and see if they say, this does not quite look right. I'm going to send you to an oculoplastic surgeon. Endocrinologists also can sometimes pick it up. Depends on how closely they're looking for it. And so what will happen then is you come see an oculoplastic surgeon, and we'll go through the entire orbital examination, which will involve checking your eye movements, checking to see how far your eyes are out from your skull, checking to see where your eyelids are sitting at, checking your vision, checking to see the surface of your eye, checking the whole periocular structure. And then, depending on the severity of it, because thyroid eye disease can go from, I just have some dryness in my eyes, it's kind of irritated, to I'm going to lose my eyeball. And anywhere in between, we will treat it based on that. And there's a whole host of treatments. And one of the more recent things that came out was teprotumumab. Try to say that one a couple times.
Of course. teprotumumab.
Not so easy.
Yeah, I know it's not easy at all. Any of these biologic agents all have very, very bizarre names, and they all end in mab. And I think I had it in our previous episode. We talked a little bit about that, but this is one of them.
Yeah. So teprotumumab, its trade name is Tepeza, has been really a game changer in terms of how we treat thyroid eye disease. 10 years ago, and I remember when I first started my training, we kind of would leave people at a certain level. So even if it was, we typically stratify people into mild, moderate, severe. You were really only going to get treatment if you were in the moderate, progressing towards severe, at least in the active phase. Thyroid eye disease has two phases. An active phase, or it gets worse, typically takes between about 6 months to 2 years. Then it'll get a little bit better, and then it kind of reaches a steady state and vacillates for a while. In that active phase, we would really only treat you, in most cases, if it was really getting bad and there was some sort of permanent damage that could happen to your eye. So that was steroids, high dose, radiation therapy, or surgery. That's all we had. Teprotumumab came along, which specifically targets...
And this is how long ago now it came into the picture?
It's within the past decade.
Okay.
I don't
So
remember
it's relatively,
the exact...
from our work perspective, relatively new.
Yeah. And it really changed how we treat it, because that medication specifically targets the insulin-like growth factor, which is a IGR1F, which is a very specific target for thyroid eye disease. And I have seen people go from looking really bad with their thyroid eye disease, they can't even recognize themselves, to returning to the way that they looked prior to the thyroid eye disease kicking in.
That's great.
And in many cases, it can do things that we can't even do with surgery, because it actually affects the exact receptors involved with the disease. So when this came out, it really changed the way that we can treat thyroid eye disease patients. We can delay the surgeries that are needed. Sometimes we don't need the surgeries, and the surgeries for thyroid eye disease can be big surgeries, and they're split over many steps. Sometimes we still need to use the steroids, especially in a really acute situation. Very, very rarely do we ever need to use radiation, which really wasn't a good
choice
treatment in general. So because of the success of that medication, now we're getting more medications that are going to be coming out probably in the next year. So great. Second generation of these medications, along with even a separate class of medication.
Because not everyone tolerates this medication well.
Correct. It has lots of side effects. And they're real side effects, but they're helpful in terms of getting your eyes back to normal. And most people will tolerate the side effects. Very, very few people. I think I can only think of 2 people that said, please take me off of this medication. The newer ones, so right now Tepeza, teprotumumab, is an infusion therapy. So people got to go in, it's 8 weeks, got to go into a center, get an IV. No one really wants to get infusions. It's kind of a big deal. The newer medications...
It's a big commitment for people to kind of go sit down in a chair, and I don't know how many hours it takes, but probably a while.
It's only about an hour. You still got to make it over to the center. You got to get an IV. You got to get the infusion. Typically, people get cramps afterwards, which can be very annoying. So, and it's 8 weeks. Or, I'm sorry, 8 infusions over 3 weeks at a piece, which is a pretty long time. The newer medications are going to be like a sub-Q injection. So kind of like people would give themselves insulin, or the newer medications, Ozempic, EpiPens, stuff like that, and a pill form, and then some other infusions. So we're going to have more convenient medications that hopefully we can start earlier without as many side effects. So those are all in their phase 3 clinical trials. Probably be out within the year or 2.
That's great.
Yeah.
So far, the information about each of those is looking promising. They're not looking like they have to be pulled.
No,
which is good.
They all have had. We got some preliminary data at our most recent big meeting.
Okay.
They all had basically equal effects to Tepeza, and side effect profile was slightly better.
Okay.
So we'll see once they finish the phase 3, but so far so good.
Okay. So this is great information, Steve, and I know that a lot of people would be interested to know more about not just IMPESA or whatever the proper name is for it, and the other ones that are going to be coming out, especially people who are suffering with this problem. When it gets to the point that they need surgery, now obviously I know the answer to this question, but I want you to tell them what typically has to happen. What's the issue? What are we trying to do? What are we trying to accomplish?
So thyroid eye disease surgery basically gets split into 3 parts: the orbit, the eye muscle, the eyelid. So the first part is the orbit, and as we talked about, you get the congestion. That congestion can squeeze like a python.
And I'm going to iterate for people, congestion, when Dr. Winkler is talking about this, he's talking about blood vessels not emptying out properly from the orbit, so everything is just getting backed up. Think of it like plumbing in your house. It just gets backed up and it's not draining appropriately, and all of a sudden, bad things happen.
So you get enlargement of the muscles, get enlargement of the fat. The muscles, as they enlarge, is really the problem because they can squeeze. The orbit looks like a pyramid, but flipped on its side. All the important stuff comes out the very top of the pyramid. And that little space is quite small. If you get a lot of backup inflammation congestion there, it can squeeze the nerve that connects your eyeball to your brain. It can squeeze the nerves that move your eyeballs, and it can stop, again, the blood vessels from exiting the orbit, which then perpetuates it. So then it gets more inflammation and more backup and more congestion. And that's what leads to like the Charlie horse pain and everything. So
you're leading into basically a perpetual cycle.
Yeah. And so what happens is that in that case, if it really starts getting bad, or long term, the eye is so far forward that there's no other real options for treatment, we have to remove the bone around the eye to open up the orbit and the space to allow the eye to sink back to its more anatomic, natural position. Also, by opening up that space, it kind of lets the orbit breathe. So imagine something squeezing, and then you relax those walls. Now all of a sudden you have all this more space for the inflammation to basically leak out. And the blood vessels can all of a sudden are no longer being compressed. The nerve is no longer being compressed. And so that's the first phase of surgery. So that's the most important in terms of protecting the eyeball.
But not everybody who has thyroid eye disease has to get that up front.
It's very few people that have thyroid eye disease who actually need an orbital decompression surgery.
Okay.
So that's pretty rare, especially with the newer medications. The other problem is that sometimes when the fat, so right, you have the muscles and the fat of the orbit, if the fat really expands, it's basically like pushing a ping pong ball in a cup of water, and you just keep pouring water in. The ping pong ball will keep floating to the top of the cup of water. Well, the fat acts similarly. It doesn't compress as much, but it will push outward. So if the eye becomes so far forward and medications are no longer working and there's so much extra this fat, well, we have to open up the space. You can't just remove the fat because within the fat, all of the wires, so the nerves, the muscles, they all kind of intertwine, and you can cut something very easily. So you have to actually allow that space to open up. So that's the other reason why. So 2 reasons mostly. One is the eye is pushed so far forward that you're seeing okay, but it's too far outside of the the skull. And then 2 is that the muscles themselves are pinching off the nerve, and you're at risk for losing vision. And we have taken care of both here
on many occasions. So it's not a new thing for us. That's a great synopsis of everything related to thyroid eye disease, Steve.
Well, that's just the first part.
Yeah.
Let me stop you right there. Number 2, then you got to get your eye muscles fixed.
Oh, yeah. Well, there we go. That's the secondary part.
Yeah.
This really, truly is part of the plastic portion of what you do.
The first part is.
Yeah.
The second part is then getting your eye muscles fixed off. So that will go to somebody who's used to dealing with that. So a strabismus surgeon. The reason why is that even though there's only 6 muscles in the eye, they all have to work in coordination. And your eyes are very sensitive to being misaligned. And a lot of people come in saying, I got double vision. And so then once we check them out, we say, oh, it's thyroid eye disease related. So once we know the orbit is stable, because changing the bone structure, changing where everything sits at, will change how the muscles move. You wait till everything settles, all the inflammation, the muscles realign themselves as best as they can. You get your muscles altered or adjusted. So that's from a strabismus surgeon. That's a fairly quick outpatient procedure in most cases. Then we wait after that. Then the final part is when you come back to me, then is when we start getting the eyelids kind of back to their baseline or best place. So in most cases in thyroid eye disease, the eyelids open up too high. It has to do with the inflammation specifically of one of the muscles called Mueller's muscle. And its analog in the bottom eyelid, capsulopalpebral fascia. So you get this thing called eyelid retraction.
Fast.
I can do it.
I'm sure you can.
That doesn't mean I want to.
Okay.
So those two give you the wide eye look in addition to where the eye sits. So that's the last thing to kind of fix because the orbit position will change the eyelid height and where they sit on the eyeball. The muscles behind the eye, around the eye, can change the eyelid height. So you got to take care of those. And then once everything settles out, then we take care of the eyelids. And usually it involves lowering, sometimes elevating the eyelid. Sometimes we have to add extra tissue. Sometimes we have to build up the tissue around the face to help the eyelids sit higher. So,
and it's not necessarily that if a person needs orbital decompression surgery, they're going to need all those elements then afterwards.
Correct. We don't always go that route. Sometimes we say orbits are fine. Sometimes we say you need eye muscles. And sometimes we say, okay, everything's stable. We just need to fix your eyelid. But that is the progression. And sometimes it can be a long process. It's not something that's simple and easy to take care of, as you can tell.
Absolutely. Well, I can't thank you enough for being here today, Steve. This was a fantastic discussion about thyroid eye disease and everything related to your journey into medicine and both into how you got into ophthalmology. I thank your father for inspiring you, because otherwise you would not be here with us today, which is great. And we're very blessed to have you as part of the team, but I'm sure the community is equally thankful because they're learning a lot now about things that may be affecting them and what to do next. I think the big take-home points from my perspective for you guys to remember is if you're having these kinds of symptoms of eye pain or difficulty with your vision or things just becoming more prominent with the eye coming forward, very simply, you don't have to diagnose yourself at this stage. Just make sure you go see a professional like Dr. Winkler or his sister or one of his family members to help you determine, is that actually what's happening or is it something else? Because a lot of these things do have treatments and you can be helped. You do not need to suffer with them up front. And I think you'd agree with that. So from that perspective, thank you so much for being here. And thank you guys for tuning in to another episode of the IMG podcast. I look forward to seeing you guys next time. Make sure to tune in to all of our socials, and we hope to see you soon.